started the preparation for our general surgery subject. We have already discussed some topics. Today we will study wound. The topics which are already discussed are shock and hemorrhage, septicemia, burn, blood transfusion, ATLS, aseptic technique and sterilization, nutrition, enteral feeding, parenteral nutrition, gangrene and amputation, fournier gangrene, and gas gangrene. These topics are already discussed in the first 3 videos which I have uploaded. Now we will start from wound. What are the important things that we will learn in this chapter? These are enumerate phases of wound healing. What are the classes of wound? What are the complications? What is the diagnosis, management and risk factors for pain in wound, discharge from wound, and small bowel protruded from wound, and surgery history, and what are the predisposing factors, and what is the treatment option. All we will discuss in this video. So starting from wound dehiscence. What is the definition of wound? It is partial or total disruption of any or all layers of operative wound risk factors. Okay, this one is right. So, now what is the definition? It is partial or total disruption of any or all layers of operative wound. What are the risk factors? Risk factors are local risk factors and systemic risk factors. The local risk factors involve inadequate closure of wound, raised intra-abdominal pressure, and deficient wound healing. While the systemic risk factors are age above 60 years, diabetes mellitus, uremia, jaundice, sepsis, smoking, obesity, and constipation. How we will manage? So for the management, first we will start from investigation. We will do the CBC, that is infection. In case of infection, the total leukocyte counts increase, so we will do the CBC for that. Blood culture is done for causing infectious organism. Blood glucose is checked in case of diabetes. Blood urea is done and LFTs are done. What are the treatment options? First of all, reassure the patient, then give morphine and antiemetics, resuscitate if in shock, then nil by mouth and NC tube insertion and suction. Antibiotics are given, cover wound with saline, soak towel and shift to OT. Remove if any gangrenous tissue is present. Operation is replacement of bowel and repairing of wound. Okay. Avoid tight suturing, stitch all layers of abdomen, control all the risk factors, treat cause responsible for it. So how we will provide the treatment? First reassure the patient, then do all the general measures and then cause the responsible factors for it. Coming towards the wound classification, we have two main classification of wound. The first one is Rank and Wakefield's classification, which is the most simple classification, and the second one is due to others different factors. The first one is Ranke and Wakefield's classification, which contain the tidy shape, sharp, clean edges, and these are caused by sharp objects. While the second one is they involve the crushed, burned, avulsed, or mangled parts. These wounds are dirty and contaminated. The other classifications are closed wound classification, that is abrasion, bruises, contusions, and hematoma are closed wounds, while the open are ulceration, laceration, cuts, puncture, and crush injury. The third one is classification by causes. These contain traumatic, iatrogenic, and burns. The fourth one is length of time. Acute is less than 6 weeks and chronic is greater than 6 weeks. And the fifth one is classification based on the mode of injury. Then we have the different phases of wound healing. The first one is the inflammatory phase, which is regenerative and reparative phase. It is immediate reaction by tissues which initiate healing and limit further damage by formation of fibrin clot mesh with platelets, by release of coagulation factors and cytokines. The second one is proliferative phase, also known as regenerative or reparative phase, 2 days to 3 weeks. Combined process of epithelialization, fibroplasia, and diogenesis occur in order to replace dead and missing tissues. The third one is maturational phase or remodeling phase, which contains 3 weeks to 2 years. New matrix contracts with cross-linkage of collagen and the scar tissue matures with loss of edema. The fourth one is we have the complications of non-healing wound ulcers, which are amyloidosis, bacteremia, cellulitis, endocarditis, heterotrophic bone formation, maggot infestation, meningitis, osteomyelitis, perianal urethral fistula, pseudoendorism, septic arthritis, sinus tract or abscess, squamous cell carcinoma. These are the complications of non-healing wounds. The management of acute wounds and ulcers, scar, keloids, and hypertrophic scar definitions are also present in the chapter. If you want to study that, then you can go for the book. Okay. Okay, so starting from chronic leg ulcers, what we will be discussing in this chapter, we will discuss the definition, the causes, examination and investigation, management of venous ulcers, and what is the management after you had ulcers. Then we will discuss the venous ulcers and the diabetic ulcers. Okay, what is ulcer? Ulcer is the discontinuity of skin and mucous membrane which occurs due to microscopic death of tissues. What are the causes of ulcers? The causes are traumatic ulceration, diabetes, venous diseases, immunodeficient arterial diseases, pressure sore or decubitus, malignancies, diabetic neuropathy, and infections. These are the most common causes of chronic leg ulcers. Then we will do the examination for ulcers. What we will do, first of all, we will do the inspection and palpation. On expression, we will see the side shape and size, the margin, the edge, the floor, and the base, and the discharge and the surrounding tissues. On the palpation, we will check for the temperature and tenderness. Then we will check for focal examination of lymph node, artery, and vein. Then we will check the movement of joint, distal and proximal. Then we will map area of ulcer with loss of sensation. Then we will do the systemic examination. What are the investigations options? For investigation, we will do the biopsy of ulcer for malignancy. Then we will do the Doppler ultrasound, the Doppler measurement of ulcers. Then we will do the ankle BP, and then we will do the ankle brachial pressure index, and we will do the blood glucose test. What is the treatment of ulcer? The treatment of ulcer we will discuss later in the venous ulcer and the diabetic ulcer. In the management, once the ulcer is healed, how we will manage the ulcer when it is healed? When the ulcer is healed, patients should be encouraged to wear compression stocking and proper hygiene and elevate the foot whenever possible. Okay, now coming towards venous ulcer. In venous ulcer, we will learn the diagnosis, investigation, treatment, and complications. What is venous ulcer? It is the most common cause of leg ulcers. Is chronic venous insufficiency. It is caused by damage to venous valves leading to venous hypertension, stasis of blood, and extravasation of blood into subcutaneous tissue. Three theories are there which explain venous ulcer. These are fibrin cuff theory, white cell theory, and macromolecules. What are the investigation options for venous ulcers? These are venous ulcers are diagnosed by clinical examination. Non-invasive venous imaging with duplex ultrasonography assess reflux and obstruction in superficial, deep, and perforating veins and is indicated if the diagnosis is not clear or if surgical intervention is being considered. What are the treatment options of venous ulcer? These are general treatment and the specific treatment. Okay, in general treatment, there are 10 commandments of treatment of venous ulcer. These are: you should take rest with leg elevated above head, receive antibiotics if infection exists, apply wound cover with treatable dressings, apply compression stockings, do venous Doppler to rule out DVT, consider surgery only when infection is cured, ligate long or short vein if incompetent, ensure that all perforators are ligated, should tell long look accessory long saphenous vein near the termination of vein if present, ligate it, otherwise definite chances of recurrence, and should lose weight. These are the general measurement for the treatment of venous ulcer. What are the specific treatment? In specific, you have to do the compression first. Treating and decreasing risk of developing new ulcers involve controlling edema by compression therapy. Then we will do the pharmacotherapy, that is topical antibiotics, Norol and pentoxifylline is helpful to some extent. Then we will do the vein stripping, that is in patients with superficial venous insufficiency, shipping incompetent veins can prevent recurrent ulceration. Then we will do the skin grafting. In skin grafting is used to aid healing in large ulcers. What are the complications of venous ulcers? These are venous dermatitis, lipodermatosclerosis, cellulitis, osteomyelitis, and malignant changes. These are the complications. Okay, what are the clinical features of ulcers? These are irregular shape, well-defined border cover with yellow-white exudate surrounded by erythematous skin, usually in distal and medial aspect of leg. What is chronic leg ulcer? It is defined as a defect in skin below level of knee, persisting for more than 6 weeks and shows no tendency to heal after 3 or more months. What is the etiology? It is DVT. She had swollen legs for many years. Chronic leg ulcer is usually venous ulcer of leg. Now coming towards diabetic ulcer, which is very important topic. What we will be discussing here: the diabetic foot and its pathology, the investigations, the treatment, what factors in diabetes lead to gangrene, preparation of diabetic patient for surgery and treatment. The diabetic ulcer affect 1 in 10 patients of diabetes. Patients with diabetes have increased risk of lower extremity amputations and main cause is diabetic peripheral arterial disease accelerated by direct damage to nerves and blood vessels by high blood glucose level. Now, what is the pathology? In pathology, we have vasa nervosa microangiopathy, that is nerve damage due to disease of vasa nervosum, resulting in a glow and stalking sensory motor neuropathy. Then, sensory neuropathy occur results in loss of protective sensation of pain, heat, and pressure, making patient unaware of actual ulceration. Then autonomic neuropathy occur lead to arteriovenous shunting, compromising blood flow to the capillaries. Then motor neuropathy occur in which results in denervation of small muscles of foot, leading to deformity of foot, which results in ulceration. And then the reduced immunity occur which lead to loss of actin and myosin, which impair chemotaxis. Now, what are the factors that contribute to the development of gangrene? These are arteritis with neuropathy in diabetic, thrombosis of atherosclerotic artery, smoking, abscess formation, infection from arterial occlusion, and trauma. These are the factors that contribute to the development of gangrene. Now, how you will prepare the patient of diabetic foot for surgery? First of all, you will take the pre-op history, that is onset of diabetes mellitus, duration, control, medication, complications, peripheral neuropathy, previous ulcer and treatment, vascular diseases, and family history. Then we will do the examination of the diabetic foot. Then we will do the inspection of ulcer site, size, age, margins, floor, base, surrounding areas, foot deformity, and color. Then palpation is done and temperature, tenderness is checked, margins and base of ulcer is checked, and peripheral pulse is checked. Nerve examination is done and the reflexes are checked. Then we will do the investigations CBC and ESR is done, blood glucose and SbA1c is done, urine glucose, ketone bodies and urine RE is done, culture and sensitivity of wound sample is done. X-ray bone of soft tissues and osteomyelitis etc. is done. Doppler ultrasound is done. CT, MRI and bone scan. Ankle brachial pressure index normal 1:1. Spirometry for pulmonary function is done. Echo ECG for CVS function and RFT is done. Now, what is the pre-op management of diabetes mellitus? First of all, admit the patient day before surgery, then be first on list. Stop long-acting insulin night before surgery. Do RBS and HbA1c. Check glucose and electrolyte on morning of surgery. Don't give normal dose insulin. Start IV insulin 10 to 20 units sliding scale. Maintain good glycemic control. Now, how will you manage and treat the patient? Principle of diabetic foot. What are the principles? First of all, you will do the general control, that is glycemic control is equal to normalized glucose level. Control of infection, that is antibiotic coverage. Then relief pressure at ulcer site. Debridement of necrotic tissue when pink. Apply skin graft. Care of patient as a whole. Amputation may be an option if ulcer is not healing, leading to gangrene and severe cases. Now, what are the principles of treatment? Relief of pressure at ulcer site, control of infection, and aggressive surgical treatment. What is the surgical treatment for diabetic foot? It depends on the grading. This is the grading of diabetic foot. The grade 0 is foot at risk. The grade 1 is superficial ulcer. Grade 2 deep ulcer with involvement of tendons, joint, and capsule. Grade 3 is deep ulcer with abscess formation or osteomyelitis. Grade 4 is forefoot gangrene and grade 5 is whole foot gangrene. Now, how we will provide the surgical treatment according to the grading? At grade 0, need good serum sugar control. At grade 1 and 2, you have to need the excision of dead tissues. Grade 3 can require extensive debridement of necrotic tissues including bone. Grade 4 require forefoot amputation and grade 5 require the below knee amputation. So, in this section, we discuss the ulcer. First of all, we define what is general ulcer and what are the treatment options. What are the causes, how we will examine ulcer, and what are the management once the ulcer is healed. Then we discuss the venous ulcers, what are the investigations for venous ulcer, what is the treatment option. Then we discuss the general treatment and then the specific treatment. In specific treatment, we have 4 main steps, that is compression, pharmacotherapy, vein stripping and skin grafting. Then we will, what are the complications, what are the clinical features, and what is chronic leg ulcer and what is the etiology. Then we discuss the diabetic ulcer or diabetic foot, what are its clinical features, what is the pathology, what are the five steps, that is vasa nervosum, sensory neuropathy, autonomic neuropathy, motor neuropathy, and reduced immunity. These all include the pathology. Then what are the factors that contribute to the development of gangrene? Then we discuss the preparation of diabetic patient for surgery. First of all, we will do the pre-op history, then examination, then inspection, palpation. Then we will do the investigation. Then we will manage the patient for pre-op diabetes. Then what is the management and treatment principle for the diabetic foot? First of all, general treatment is provided. Then principal treatments are provided. Then surgical treatment is done, and then the grading of the diabetic foot is. Then surgical treatment is provided according to the grade of the diabetic foot. Then we have discussed what are the different grades of diabetic foot. Okay, now coming towards decubitus ulcer. What we will discuss here: the bedridden patient falls smelling wound on. What are the most common sites of decubitus ulcer and affected sites, and what is the prevention and treatment options, and what are the complications of decubitus ulcer? We will discuss in this section. What is decubitus ulcer? It is also known as bed sores. What is the definition? These are also called bed sores or pressure sores or decubitus and represented very serious complication among bedridden patients. Ulcer is formed when tissues compressed between bone and supporting structures such as bed or wheel, etc. Okay, so okay. So, what is the definition? These are also called bed sores, and how it occur when the pressure is applied between the bone and tissues and the supporting structure, that is bed, etc. Then, due to it, the ulcer that is caused is called as decubitus ulcers. Now, what are the common sites for decubitus ulcers? These are soft tissues and supporting structures. In soft tissues compressed between bony prominence, for example, ischium, sacrum, and trochanters, while the supporting structures are bed, wheel, chair, including buttocks, shoulder, heel, ear, head, back of knee, etc. How it can be prevented? The decubitus ulcers can be prevented by providing good skin care, regular skin inspection, especially over bony prominence. Any signs of redness, abrasions noted, pressure must be taken of keep skin dry and clean. Okay, how it can be prevented? When you provide the best skin care and the regular skin inspection, especially over bony prominence. Any signs of redness, abrasion noted, pressure must be taken off and keeps the skin dry and clean. Okay. Now apply the talcum powder. How we will provide the good skincare? This is the procedure. Apply talcum powder. Gently massage with lanolin lotion. Then clothing and bedding must be wrinkle free, made of porous absorbent material to allow air circulation. Air mattresses should be provided. Frequent change of position round the clock every 2 hours, and patient and family education should be provided. Now, what are the treatment options for decubitus ulcers? These are the conservative treatment. Change position of patient every 15 minutes or at least every 2 hours, using supportive cushions, mattress, and beds. Keep wound clean. Wash it with water and mild soap, and avoid antiseptics. Dressing with moist gauze to keep wound moist and absorb excess fluid. Apply hydrogel or alginate, highly absorptive dressing. Then antimicrobial dressing helps to prevent and treat infection, release muscle spasm, and give diazepam and dantrolene. What is the surgical treatment for the decubitus ulcer? These are removal and debridement of the damaged tissue, and negative pressure wound therapy, that is vacuum assisted closure, and tissue flap is applied. What are the complications? Cellulitis, bone, a joint infection, septic arthritis, osteomyelitis, sepsis, and squamous cell carcinoma may occur due to decubitus ulcer. So, what we discuss in the decubitus ulcer? Its definition. What are the common sites? These are soft tissues and supporting structures. How we can prevent a decubitus ulcer? By good skin care. What is the treatment option? There is conservative treatment and the surgical treatment. And then, what are the complications that can occur due to this decubitus ulcer? We have discussed in this section. We have a small minor topic, that is needles and sutures. So, what are the different types of needles? These are curved needles, straight needles, cutting needles, and round body needles. There are two main types of sutures. These are absorbable sutures and non-absorbable sutures. In the absorbable, we have catgut, which is natural and made up of sheep, while the visceral are synthetic. The catgut is used for the closure of bladder, while the visceral is used for the gut anastomosis. In the non-absorbable suture, we have proline and silk. Proline is synthetic, which is used for the abdominal wall closure and herniorrhaphy, while the silk is made up of cocoon of silkworm, which is widely available and which is used for the skin closure. What is surgical audit? It is a systemic critical analysis of quality of medical care provision, which includes the procedures used for diagnosis and treatment, resources utilized, outcome, and quality of life of the patient, carried out by those personally engaged in activity concerned, is known as surgical audit. The audited cycle contains main steps, which are the topic selection, the setting criteria and standards, the first data collection, then evaluate and compare with set criteria and standards, then implementing the changes, and then the second data collection. We will be discussing the topic fluids and electrolytes in our next section. Thank you.